Hi, everyone, and welcome to our webinar series, To Immunity and Beyond, focusing on immunity and infection in donation and transplantation. My name is Erica, and I will be today's moderator. Firstly, I'd like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for the diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saluto, Anishinaabe, Inuit, and any others whose histories, languages, and cultures continue to influence our vibrant communities. I encourage you to write your land acknowledgement in the chat box. We also would like to acknowledge CIHR, whose generous support enabled us to host these sessions. Today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have a question or a comment, you can raise your hand with the raise hand button or type it in the comment sections. We are pleased to have Dr. Mamatha Bhat and her postdoctoral fellow, Dr. Soumita Ghosh, present their research titled Leveraging AI for Biomarker Identification in Liver Graft Pathology. Dr. Mamatha Bhat is a scientist at the Ajmera Transplant Centre, University Health Network, and an assistant professor in Gastroenterology and Hepatology at the University of Toronto. She's trained at McGill University, followed by a Transplant Hepatology Fellowship at the Mayo Clinic and a PhD in Medical Biophysics. Her research focuses on advancing precision medicine approaches to long-term complications after liver transplantation by integrating clinical data with machine learning and multi-omics analysis. She's received funding from organizations including CIHR and has published over 100 papers in leading journals. Dr. Soumita Ghosh is a postdoctoral fellow at the Ajmera Transplant Centre, University Health Network, supervised by Dr. Bhat. Her research focuses on developing machine learning approaches to integrating omics and clinical data with applications in transplantation and liver disease. Speaking for myself and hopefully many others, I'm very excited to hear about your presentation. I will now hand it over to you.
Thank you. Thank you, Erica. I'll now share my screen. Hello, everyone. Good afternoon. Today, I'm going to present our work on leveraging AI for biomarker identification in liver graft pathology. The outline of my presentation is as follows. First, I'll introduce what machine learning and artificial intelligence is. Next, I'll talk about the impact of AI in translational research. After that, I'll invite Dr. Bhat to give us the project background and clinical significance and translational impact, after which I will present results and conclusions. What is machine learning and artificial intelligence? Machine learning is a subset of AI, particularly useful for learning interrelationships between variables from data without the need for explicitly programming them. It is able to detect hidden patterns within large data sets. Deep learning is a further refined subset within machine learning, which is able to learn complex relationships, multiple parameters and layers, and we can model complex problems, complex biological problems. Science in the age of AI. Now, AI has influenced almost all stages of scientific processes, including hypothesis formation, experimental design, data collection, and analysis. While AI cannot replace scientists, it can definitely augment and accelerate research at each step of the process. And it can also ensure objectivity in experimental analysis. The most common machine learning paradigms are supervised and unsupervised learning. In supervised learning, data and label are given to the model during training, and the model learns to predict that label. Whereas in unsupervised learning, the model learns from the data and is more exploratory and discovery based. The impact of AI in translational research. So in a typical omics analysis pipelines, you will often find that most studies interrogate a subset of omics modalities from the molecular hierarchy. Often during the feature selection step, prior biological knowledge or what has been established in the field is commonly integrated to improve or refine feature selection. Based on that, we model the different downstream tasks. Now, the different downstream tasks could be prognostic, diagnostic, therapeutic, or could be more exploratory, like finding disease mechanisms, molecular subtyping, or biomarker discovery. The case for AI in biomarker discovery: recent advancements in omics technologies have enhanced biomarker discovery. However, with that comes the complexity which necessitates the use of AI. Next, I'm going to present our study, which is titled as a multimodal machine learning biomarker for non-invasive diagnosis of liver graft injury. To provide the clinical significance and translational impact of this study, I would now invite Dr. Mamatha Bhat to present the next set of slides.
Yeah, sure. So thanks so much, Soumita. So in terms of clinical background, in our liver transplant recipients, over time post-transplant, many individuals will have injury of the graft. The most common causes of graft injury are T-cell mediated rejection, especially earlier on post-transplant, but in the longer term as well, there can be later or late T-cell mediated rejection. There can also be fatty liver disease or metabolic associated steatohepatitis in the new liver over time, especially in patients who have diabetes. There can be other causes of graft injury, such as bile duct complications or viral infections. But really the most common competing diagnoses beyond a year post-transplant are rejection versus MASH or fatty liver disease. And, the important thing to recognize is that the management of these two competing causes of liver graft injury are quite different. In one, you have to increase the anti-rejection medication, and the other, you need to consider decreasing the anti-rejection medication. So in rejection, you would increase, whereas in MASH, you would decrease, and also treat the MASH, perhaps using GLP-1 receptor agonists. So currently, the only way to diagnose the cause of injury is with a liver biopsy. Although we'll see patterns in the liver tests and, based on clinical context, we may have a certain probability of the problem being rejection or MASH. This is difficult and actually impossible to know unless you actually do a liver biopsy. And a significant concern is that with any ongoing liver injury, liver graft injury, you can develop cirrhosis over time. And in transplants, in grafts, for any given degree of injury, you can have more accelerated fibrosis or scarring of the liver. So this is why it's particularly important to try to be as precise as possible in the diagnosis of injury, like what is the cause of liver injury, but you can only do that with an invasive test, which is the liver biopsy. So there is certainly a need for non-invasive biomarkers that could be performed even serially. So when you make modifications to the anti-rejection medication, being able to tell whether in a particular individual, there is rejection versus some other cause is important. And there is a significant need for non-invasive tests to be able to guide precise and personalized management. So, often as liver physicians, we'll look at the patterns in the blood tests as well as the clinical context. So the physician will often have a hunch based on patient profile and test patterns. And so, for example, if you have a young liver transplant recipient and their enzymes are in the 100 to 200 range, and you recently decreased their immunosuppression a bit, and you have ALT greater than AST and elevated alkaline phosphatase, then it's most likely to be T-cell mediated rejection or rejection. So we often look at patterns in the tests as well as clinical data, but as I said, it's difficult to tell that because there are also dynamics in the data, and things can be even more complex, depending on the patient. We published a paper last year. So this was a multi-class artificial neural network, or an AI model, that leveraged longitudinal clinical and laboratory data over the week preceding a biopsy. So for any patient who had elevated liver tests, we looked at their clinical and laboratory data over the week preceding the biopsy and developed a multi-class AI model. So an AI model that could classify the cause of graft injury, considering 6 different classes of graft injury, as opposed to just looking at yes, no. So rather than a yes, no answer, we were really trying to determine which category of liver injury a particular patient fit into. And so this particular model was very well performing overall. It had quite a good AUC, or area under the ROC curve, of 0.866. So this had excellent performance overall in detecting the cause of liver graft pathology. So we also were interested in seeing how well this model performed versus clinicians. And in fact, the AI model was better performing overall than clinicians in terms of recognizing patterns and predicting what was the likely diagnosis. This included 5 hepatologists and 7 transplant hepatology fellows, but overall the machine learning model was better performing. However, for some cases of rejection, the clinicians were better able to identify those biopsies. And so we looked at why that was, and then identified certain clinical decision rules that the AI model was not recognizing, and decided to teach this AI model those clinical decision rules. And by doing that, by bringing the human into the loop to teach the model, we were able to further increase the performance in terms of diagnosis of ACR, or T-cell mediated rejection. We published this work in Nature Communications last year. We then, externally validated. So external validation refers to seeing how well this model performs in other places, in other institutions. So looking at our own data set versus, we also looked at data from the Mayo Clinic, Medical Hospital of Hanover, and then finally NUHS in Singapore. So 3 very different clinical settings and countries. And in fact, the model was quite well performing overall in those other clinical contexts. It was lesser performing in Singapore particularly, but the numbers were a bit smaller. So I think the power was not sufficient for us to really evaluate the performance elsewhere. But overall, what this tells us is that this AI model was able to work quite well in other settings outside of our own institution. And it was a very important representation of an AI model being able to work in international settings outside of our own institution. So this is called generalization, or generalizability of an AI model. And this work showed us the potential for pretty good generalizability of an AI model in transplant. So now I'll turn it back over to Soumita regarding, how we're very interested in this work to use the blood test biomarker that she will describe to refine the way in which we can prescribe immunosuppression based on individual patient profiles.
Thank you, Dr. Bhat. So basically, to reiterate what Dr. Bhat mentioned, there is a diagnostic gap where individualized suppression is unachievable without a cause-specific diagnosis. And in order to safely minimize exposure or immunosuppression exposure, depending on distinguishing between graft injury, which is caused by immune-mediated rejection, or that caused by metabolic disease is imperative, because that will set the stage how immune suppression regimen can be adjusted and long-term graft failure can be overcome. So I'll describe the study that we have conducted and the results. So for this study, we have used this technology called cell-free DNA methylation sequencing, where we have profiled cell-free DNA methylation patterns in plasma, which was derived from patients. Now, cell-free DNA is a method in which cell-free DNA is actually released into the bloodstream whenever there is an ongoing injury or cell death. Donor-derived cell-free DNA is now extensively being evaluated by companies as well as various labs as a non-invasive diagnostic tool or a disease monitoring tool in different outcomes. However, donor-derived cell-free DNA lacks the advantage of tissue specificity, which we think DNA methylation patterns can provide. So, because methylation-based deconvolution can distinguish between hepatocyte and immune cell contributions, which ultimately drives the different graft pathologies. So for this study, we have data from two centers, UHN and Medical School Hanover. We have profiled over 125 LT recipients. We have profiled their methylation patterns in circulating DNA. So the broader group categories that they belong to are TCMR, MASH, and controls, post-transplant with normal liver enzymes levels. We have performed bioinformatics analysis where we have extracted the sequencing data, looked for quality control, etc. We have done differential methylation analysis, checked for enrichment, pathway enrichment, or pathways that are enriched in each of these graft pathologies, as well as we have done a machine learning pipeline where we are able to develop an AI diagnostic tool, which can distinguish between primarily MASH versus TCMR. In terms of patient summary statistics, we see that the liver enzymes, particularly ALT, AST, are relatively higher in MASH LT, but highest in patients with TCMR when compared to that of controls. In terms of primary indication for transplant, we see that particularly the UHN cohort consisted of patients with MASH post-transplant. Majority of them had primary indication for transplant as MASH at the time of biopsy, at the time of data collection, plasma derivation. In terms of immunosuppression regimen, we saw majority of the patients in both the cohorts were on calcineurin inhibitors. Now we profile the methylation patterns of these plasma that we have derived from these patients. And we find that the methylation patterns primarily consist of intronic regions, which are the main sites of differential methylation. We see MASH post-transplant is hypermethylated compared to controls. However, hypomethylated when it's compared to TCMR. So TCMR shows an overall highest degree of hypermethylation, and it shows broad methylation patterns relative to controls as well. In terms of pathway enrichment analysis, what we try to tease out are shared and comparison-specific pathways. So we compared each of these three groups, MASH versus control, MASH versus TCMR, TCMR versus control, and we find that certain pathways are TCMR specific, which are hippo signaling pathway or T cell receptor signaling pathway. And MASH-specific pathways are PIP3 AKT signaling pathway. Next, we conduct a machine learning study, where the first step towards machine learning is feature selection. Here, in this first plot, which is a PCA principal components analysis plot, here each dot represents a sample and the color represents the graft pathology subtype. And we can see with just the clinical variables that we have collected in our study, there is poor separability between the three groups of graft pathology. However, also when we see, if we take the whole genome level methylation sites, which is about more than 5 million methylation sites, when we consider them for 300 base pair windows each, we also are not able to tease out the separability between them, although we see TCMR fairly separated from the other two subgroups. Next, we perform a feature selection where we try to bring down the dimension. This step is important because if you consider the number of patients we have, per patient, we have much more methylated sites than the actual number of patients. So it is imperative for any machine learning model to work that we bring down the dimension and to focus on disease-specific or outcome-specific features. So using this particular Boruta feature selection method, which is basically a wrapper around a random forest feature selection method, we were able to downsize or rather tease out 201 important methylated sites, which were the most informative across three of these graft pathology. Now, we take those 201 methylated sites as well as the clinical variables that we have, and we then tried out different model types, different configurations to see which model works the best. The three configurations that we chose to work on are combined model, where we fuse the two data together, methylation and clinical data, or a methylation only model and a clinical only model. This way, we could be able to tease out which model actually is the most important step towards this classification problem. So for our final classification framework, we choose this dual branch attention gated fusion network. Here, the inputs to the model are clinical data, which are lab demographic variables, then the epigenetic profile from the cell-free DNA data with the 200 key regions. And we make the machine learning model, the dual branch model, consider each of this as one branch, clinical data as one branch, epigenetic profile as the other branch. We are able to learn from both data, weigh which, for a particular patient, which data is more valuable, whether for that particular patient, clinical data was more valuable over their epigenetic profile, find hidden patterns, and also provide an uncertainty-aware decision, which means that it will provide a confidence interval as to how sure they are that this particular patient has a MASH post-transplant diagnosis. And the three diagnostic groups that we chose to classify into are controls post-transplant, MASH post-transplant, and TCMR. So I've got to mention our model, the final model of choice is the fuse model, which gives us good mean AUC and good F1 macro, considering there is imbalance between the three groups of subtypes of graft pathology. Our clinical only model performed relatively modest compared to the combined model, which influenced the methylation, which included the methylation data. More so, the methylation data itself actually was able to perform very well, which looked like clinical variables were not contributing much. So precise biology was defined by the epigenetic profile of the patient. Then we performed an interpretability analysis to see which are the top features in each of the models that contributed towards the model's decision. And we see that BMI is a key driver of differentiation in the clinical only model. In the methylation only model, we annotate each of these regions to the nearest gene that it's located to. And then what we find that many of these genes, although we are currently doing a background check with the current available evidence in the literature, we see most of these genes are implicated in liver diseases and liver fibrosis mainly. So this gives us confidence that what we are looking at is actually, if the cell-free DNA data actually reflects liver biology. Next, in a combined model, we see methylated regions dominate class-specific predictions. However, we do find one particular clinical variable, which is the transplant indication, also appear among the top indicators of, or the top influencers for the model prediction. Next, we did a per-class modality reliance study. So this particular leverages the attention gate or the per class modality reliance from the architecture that we have chosen. The unique advantage of the AI architecture that we have chosen, it kind of tells us for a particular patient which variables were important for that person's outcome prediction. And we see that TCMR predictions relied mostly or almost entirely on methylation, and MASH LT shows intermediate reliance on methylation data, whereas controls can be quickly diagnosed with only clinical variables at that time. Next, what we see in the cell-free DNA data, we always want to be sure if we are actually seeing an ongoing injury that is occurring in the liver or not. So for this, we try to do the cell type deconvolution of the cell-free DNA data. So this is an unsupervised non-negative matrix factorization method where we broadly find components or clusters within the data, much like principal components analysis, and then annotate each component to a methylation atlas. Here, the atlas that we have used is from the 2023 Nature paper from Loeffler et al., which provides an DNA methylation atlas of normal human cell types. Now, we have annotated them across, all the components were annotated across this atlas. And then for each of the components, we try to find the top ranked cell type in that component. And this is the way we teased out that broadly, if there is a mixture, however, this particular cell type dominated that particular mixture in that component. So we were able to tease out hepatocyte, immune, and other cell type contributions to the circulating methylation signal. Now we take these broadly these immune cell groups, and then we do and hepatocyte group, and then we do individualized analysis. For example, we try to see how enriched are per patient for a particular cell type. And we do find that immune enriched cell-free DNA score is significantly elevated in TCMR patients compared to controls and MASH. And we see that the difference between a TCMR patient versus control based on their immune enriched cell-free DNA, we could predict that almost correctly, almost with an AUROC of 0.72 based just on their immune enrichment. Next, we do the same for hepatocyte enrichment, and we do see that for the MASH patient, there is modest discrimination for the MASH patient when compared to TCMR, as well as control post-transplant. Next, so the results here still are on unsupervised clustering and broadly tells us based on the annotation if they are enriched in hepatocyte or immune enriched cell-free DNA. However, what we next do is an orthogonal validation where we run cell type deconvolution on actual liver biopsies. Here we have sequenced 5 TCMR patients, and each of this patient on the right, the bar chart on the right, on the left, you can see the blood cell type proportion for each of these patients. So this is a liver biopsy result, and this is cell type deconvolution on TCMR liver biopsies. We generally see that NK blood cells, the immune cell types T cell is present in TCMR, which is according to biological relevance. Also, we see NK cells dominate, and monocytes and macrophages also dominate. The reason behind this is it's partly based on the atlas that we have chosen. They have more markers for these cell types compared to T cells. So here the proportion doesn't mean the final conclusion. What it means that these proportions might vary across patients, but these cell type proportions are present across patients in the TCMR group. So this kind of validates our immune enrichment signal that we see in cell-free DNA. And it's almost similar to what we see in the liver as well. So our final conclusions here are that cell-free DNA methylation profiles from plasma, when combined with clinical variables, show promise in classifying liver graft pathology non-invasively. The dual branch attention-gated fusion network achieved the highest classification performance. So the attention gate was able to reveal biologically coherent modalities. So for TCMR predictions, it relied predominantly on methylation, thus makes the case for profiling methylation patterns from patients post-transplant, or using this as a liquid biopsy tool post-transplant for monitoring. Pathway enrichment identified disease-specific epigenetic signatures, T-cell receptor and CD28 co-stimulation pathways in TCMR, while PIP3 AKT signaling pathway very specific to MASH post-transplant. Immune-enriched cell-free DNA was significantly elevated in TCMR, and cell-side deconvolution of liver biopsies confirmed immune infiltration. Together, taking these all these analysis into holistic, we can say that our AI diagnostic tool has the potential to be a liquid biopsy marker for transplant monitoring. With that, I would like to end my presentation. I would like to thank Dr. Bhat for her supervision, as well as Sandra Holsworth. She has been a very active patient partner who has helped us review the paper manuscript, basically, and from Bhat Liver Lab, Elisa and Christina, who have worked hand in hand to make this project a success. Thank you all.
Thank you for that excellent presentation. I had a lot of fun listening to that. I'm going to open the floor now to any questions. I do see we have 2 in the chat, but as I have the floor, I will take the opportunity to ask a question. So you mentioned that you went from 5.4 million methylation sites to 2.1. Like, that's a very big jump. Can you give us a little bit more information how you refined it?
So there were multiple steps in the process. We first ran a differential methylation analysis to see which sites are important. And then we biologically refined those sites. And then with Boruta feature selection, we kind of went from, so we had around like, say, 10K sites that were important. And from there, we even further went down to 200 important informative sites, keeping in mind, because we had fewer patients to train our model on. And in technology, or in our field, there's a phrase commonly called the curse of dimensionality, where if you have too many features and too few patients that you have profiled on, it will automatically cause trouble, like overfitting the model. So it will cause trouble while generalizing it to other patient populations. So this was done, kept in mind that the topmost informative features are only retained for the analysis. However, there are other sites that are not included in the diagnostic model that are important as well. Yeah.
Follow-up question. If you had a larger sample size, would you potentially get different results?
We would try to reproduce the same results. I believe we would be able to reproduce the top 200 informative markers. That's why they had the largest effect size, and that is why they were chosen for the downstream task. If we had more than that, say, for example, if we had 10K sites or 20,000 sites, it would have become a challenge replicating that in other patient populations or when the sample size increases.
Okay, thank you so much. Very clear. Francis has two questions. We'll start with one in the chat. So he says, first of all, very interesting presentation. He gives his remarks. What obstacles would need to be overcome to implement the Graph IQ model into clinical practice?
I'll let Dr. Bhat take that question.
Well, I think there are a few steps that we need to complete. One is, in many cases, it's possible to have overlapping diagnoses. So not just one diagnosis, there can be MASH and some element of rejection at the same time. So that can happen in some cases. So we certainly need to validate this tool in a larger population. We are currently looking at further dimension reduction down to the top 10 differentially methylated sites and trying to validate those top 10, which are distinctive for the two main classes of interest. In a much larger sample set, because really our limitation is that this is quite expensive to be able to do EMC-gone samples. And practically speaking, from a clinical standpoint, it would be almost the same cost as doing a biopsy. So we do certainly want to make it more cost effective to ultimately deploy this model into clinical practice. So there are certain steps overall that we need to achieve. The other thing in terms of implementation, given that this is an AI model, we would need some automation of the data flow into the dashboard to then provide those predictions, because it's not feasible for clinicians or for anyone using this tool to consider the several variables that comprise this tool. They can't be expected to enter all of this data manually and then have an output. So that's also something that we will need to work on. So there are various steps that we need to accomplish in order to bring this to the clinical setting.
Thank you. Sandra, did you have something to add about that question, or is it a new question?
Just a comment as a patient partner on this project with Mamatha and Soumita. I think it's great that if we can, whenever we come up with these great ideas, when we can get them into practice, but this decision tool will not replace our doctors like Dr. Bhat. As a patient, though, like as our transplant centers grow, patients are outsourced out to other local healthcare providers to their area. So being able to know, especially for people who are long-term outcome, have many years outside of when they originally got their transplant, to be able to have something other than a biopsy, which is invasive, as you said, but the FibroScan is also a great way as well. But one of the things I do want to point out about this project and anything the CDTRP does, we need to translate this into plain language so that our patient, family, and donor partners can understand it. I have a good understanding of how the machine learning works and how to train and how AI works, but the biomarkers and all the details of everything that was got into the deep there weeds, it would be great to see a lay summary on this and what it means in the end to the patient. And as what the question of Francis is, how do we get it in clinic? That's always what we want to hear. The deals are great. This looks good, and especially when we get a taste of what can help our clinicians and our transplant doctors. We always want them to have those tools available, but they will never replace them or their gut instincts and their knowledge.
Thank you, Sandra. And I have good news for one of your comments. You mentioned that this needs a lay abstract or a lay summary. One of the initiatives with this new webinar series is that we are creating infographics, lay infographics. So somebody who is listening on this will be in charge of that, and we're hoping to get that circulated. So that will be a really good step forward.
Yeah, like the fast facts that we used to do when
No, it's going to be a full infographic. It's going to be an image, like just a
Great.
very quick image. What does this mean? What is the key points? What is this in a very clear way with using patient partners as people who help develop them.
Excellent.
So it's
Thank you
not
for
just
that,
academics.
Erica.
But yeah, moving on, I'm going to ask
That's great.
Francis's second question. Giving the distinct DNA methylation signature identified, have you investigated whether there are any DNMTs, methylates, that are differently expressed between your groups and that could serve as your therapeutic targets?
No, we haven't reached that stage yet. We will definitely, thank you for the suggestion. I think we would definitely explore that.
Perfect. I'll go to the next one. So this one is from Marie-Claire. Why does TCMR rely almost entirely on methylation signals while MASH shows more mixed resilience on clinical variables?
So, so to take that question, I would say like TCMR as a pathology is very distinctly, it's a very distinct pathology, which is immune cell infiltration, and it is observed in pathology reports as well as histology reports. So I guess it has a clear biological relevance, which is able to be captured more by methylation patterns, because that particular methylation patterns kind of encapsulates the epigenome of that particular patient. So it kind of gives you that level of granularity, which is perhaps for MASH, which is not required, because MASH has other indicators, clinical indicators like BMI, or very, very different set of indicators, which are both clinical as well as methylation patterns dependent. So there is an intermediate relation. I wouldn't say when it is compared to TCMR, it shows intermediate reliance on methylation patterns. However, the reliance patterns were still high compared to when you use controls as baseline to see.
Very interesting. Hopefully that answers the question. I will add another question here. So in your conclusion, you mentioned potential liquid biopsy marker. What prospective studies or validation would you need before this could replace or at least meaningfully reduce the need for liver biopsy in transplant recipients?
So currently we have in place a orthogonal validation process that we are currently conducting, where we take the top most informative targeted methylation sites, perform qPCR on them, and see if those methylated sites can itself kind of diagnose between the graft pathologies. If we are successful in that, we will broadly use that targeted methylation panel on a larger sample size, and because that would be more cost effective, as Dr. Bhat mentioned before. That would be more cost effective to run on other centers across the world. And from that, we would be able to kind of collect the data to see if it's translatable. And as you see, that would kind of show us the potential. It can be made to work alongside so basically integrate that with the electronic health records, so that when a clinician is providing a report, she has in mind what she or he has in mind what their cell methylation patterns look like. So there are several steps to reach that. First of all, we have to make these methylation patterns, as Sandra mentioned, more explainable to a patient. So, for example, a clinician is able to derive that information and pass it to a patient. It needs to be presented in a format that everyone can understand. So there are a lot of steps towards translation. However, the biggest hurdle is to get that panel to work. I think if we are able to make that panel work, we would be able to do the following steps after that and make it more actually lead to clinical impact, I would say.
Okay, that makes a lot of sense. Thank you so much. Yes.
Yeah. Thank
I
you.
have one more question, but I'm going to open it to the floor. If anybody has any questions, you may put it in the chat. If not, I will ask a closing question. Oh, Sandra, coming in last minute.
Well, I have one more because that triggered a memory for me. So
Love to hear it,
before
Sandra. Please
I
share.
before I came back to UHN and before I had the biopsy done, there's another partner, another researcher working under Dr. Bhat's lab, who did blood work on me. And so I think that was to determine sort of like biomarkers before. So what my liver looked like from blood work, I think, before the biopsy, so that can be used. Do you remember that, or can you explain how that is being used with this research? Because these are the things that patients need to know when you get your research to that level, when you want people to sign up to be part of it, right? And understand what's next.
That must have been directly related to this project. I'm guessing that was because we have been continuing to get blood samples whenever a patient gets a biopsy. If they need a biopsy for cause or if they need it as part of surveillance, we are asking patients if they're willing to provide a blood sample at the same time. Because we want to, assess whether it's possible for us to have a blood test as a replacement for a liver biopsy.
Great, thank you.
Yeah, I think the main thing here is like the possibility of surveillance over time, because it's not practically possible to do repeated liver biopsies over time. For example, based on a liver biopsy, you make a change to the immunosuppression. The liver enzymes may come down, but even if they come down, like you're not 100% sure that like you're at the right level of immunosuppression in a given patient. So being able to tell that would be ideal, just with a blood test being able to tell that. So that's what we're hoping to achieve with this. And we want to make it ultimately, cost effective. Like it shouldn't be very expensive. Like the sequencing itself here for the first development of the model was quite expensive. So now what we're trying to do is figure out a way to make it just focus on like the top 10 genes of interest that could classify the biopsies into those different groups.
Yeah, well, precision medication is very important to us. The less
Yeah,
you
so
also need to be
individualizing immunosuppression. That's the
and being
idea.
able to manage that without people going into rejection. And also, the cost of this study, but also the cost to a patient of having to go through a biopsy. There's a risk to that, as we all know.
Yeah. And plus, serially being able to evaluate the graft health is important.
Okay.
Well, thanks so much, Sandra, for your feedback and participation in this. Really appreciate it.
My pleasure. I'm always learning too. It's important to know.
And thanks for encouraging Soumita. She's been an excellent postdoc in my lab for the last few years. So she's also been acquainting herself with the clinical world, which is very different. Just getting acquainted.
See you whenever I get down there for a real clinic in person. Yeah, I remember talking to you with Christiana, and we reviewed obviously all this data that we've been reviewing today. Thank you. It's been a pleasure.
Thank you.
Beautiful. I have one last question, and if not, I'm going to call it. Dr. Bhat, you talked about this when you were answering Francis's questions very briefly, but how does the model, could you explain a little bit more how the model handles patients with mixed or coexisting pathologies?
Yeah, not yet. So we haven't looked at that as yet. That is part of the next phase of our investigations, yes. But that's an excellent question because there are coexisting pathologies. So what happens when, well, perhaps MASH could be the dominant issue on the liver biopsy. And then what happens? What kind of patterns do you get in that situation? I think that'll be very interesting for us to assess.
Stay tuned for part 2.
Stay tuned, yeah.
Yes. And on that note, Drs. Bhat and Dr. Ghosh, on behalf of myself and CDTRP, thank you so much for presenting. If anyone has any additional questions, comments, or suggested topics or speakers, please contact myself at ekcroft@live.ca. Thank you, everybody, for joining us. We hope to see you all for our next presentation on April 30th. We're going to have Dr. Andreas Ninge present his research on immune-cloaked stem cells and making them safe for cell therapies. Enjoy the rest of your days. Thank you so much for attending and
Thanks so
for
much,
presenting.
Erica. Okay,
Thank you.
thanks for the invitation. Bye-bye.